Hi, let's just quickly start with this video and then we'll do the introduction later. I really want you all to see this video, it's amazing. I'm starting this, okay?
Today in this short video, we will discuss about the cervical burnout and how to differentiate it from cervical caries. Sometimes it's really difficult to distinguish between these two. Here we will discuss about 4 differentiating points. When you are seeing a radiograph, the first point you should keep in mind is the position of the radiolucent lesion. Cervical burnout usually located closer to the alveolar crest. In contrast, caries is located closer to the tooth contact area. Next point you should remember is the appearance. Cervical burnout appears as a band-shaped radiolucency, where caries appears as an irregular radiolucency. Cervical burnout appears well demarcated on radiograph. Here you can see well demarcated border of the radiolucency. In contrast, caries appears as diffuse radiolucency. You can see here there is no well demarcated border. In cervical burnout, knife shape of the enamel at the cemento-enamel junction is intact, which is usually lost or effaced in case of caries. Hope these points will help you to differentiate these two entities.
90.
So yes, now you understood what a cervical caries looks like, right? I wanted you all to see this video because our question is going to have that. Today we are solving another question of Australian Dental Council exam, and it's again a good question which will be asked in different format in your own exam. But yes, one question on this topic will definitely be asked, and that is radiological errors. So you have to be like very well versed with the potential radiologic errors that you might encounter, and you should have a good knowledge about knowing the radiologic errors, which can be either with the bite wing film, the periapical film, or the OPG. Understood? So if you have not studied about it, please go open your radiology textbooks and read more about it. Just Google up the most common radiological errors, find a PowerPoint presentation on it, go through it, but make sure you're thorough with this topic. You want, pause this video, go read all that, take an hour or so, come back, watch the video, okay? So today's question is about a middle-aged lady visits your clinic for a routine examination. Middle-aged. Her medical history revealed that she is taking tricyclic antidepressants and anticoagulant medication warfarin. Whenever you hear this word warfarin that the patient is taking, immediately one question that should pop up in your mind is whatever procedure that you're going to do, it's going to induce bleeding. Now, depending on what procedure you're going to do, you will either be confident of doing it yourself once you take the INR, that is internationalized normal ratio of the prothrombin, which is usually 1 in normal patients, and 2 to 3 is admissible for patients taking warfarin. So depending on what kind of procedure you're going to do, either you will do it yourself after taking a consent, or if you think no, it's going to induce more bleeding and I'd rather talk to patient's GP, then you're going to refer the patient to the GP, get a clearance, and then only get it done. Understood? So warfarin is a very, very important medication, which not almost, I would say a good section of the population would be taking for some of the other medical condition, like a blood thinner has to be there in the body. She has fair overall oral hygiene, but she has some deep periodontal pockets on specific teeth. You took a series of bite wings to check her dental health and to make a treatment plan for her. Okay, so you have taken bite wings. So when you're reading this question, expect the sub questions to have the radiographs. Okay, you know where this is going, correct? It's called as, when I was giving my master's exam, it was called as leading the viva. Like you intentionally introduce some words about some topics which you are confident of while answering question about a different topic, so that the examiners are kind of asking you about those words, and then you open up a topic in which you're confident about, and then you answer it confidently Did I tell you all my MDS Viva went on for 1.5 hours? Yeah, it's no joke, 90 minutes. And my colleague, so how they picked up candidates, so we were just two, and I was the All India postgraduate ranker, and he was the state ranker. So they always went ahead with the All India postgraduate ranker. Not that it made any difference, but yeah, that's how the deal was. I remember distinctly entering the cabin somewhere around 10 o'clock, four people sitting. It's like you're gonna get hammered, and I'm just sitting over the chair like that. I came out at 11:30, and I looked at the time, and I was like, shit. I was like there for 90 minutes, but that was it. That was the second day. It's done. It's finished your Viva, and you're done with the exam. But of course, you will wait until your colleague's over. He went inside. Okay, he went inside at like say 10:45, and no, my Viva started at 10. I came at 11:30, right? Yeah, he went inside at 11:45, and I thought maybe he's gonna come back, again same 90-minute drill, and then finally we'll be done by lunch. He goes inside at 11:45. He's out at 12:10, 25 minutes. Okay. And I was like, what happened? Why are you so out? Because I was just standing outside talking to the sisters and etc. nurses out there. He's like, I'm done. I'm like, seriously? And he was like, yes. I was like, what was happening inside? And so then, yeah, I think pretty much, I guess I bored my examiners, but no, I got more marks, and I guess they just wanted to screw me more. No, but it was nice, that 1.5 hours. It was like, this is it. This is my life, like this is the turning point of my career. Either I make on this day or I don't, and this four examiners, which included one of my own guide. My guide barely asked me any questions, but for the past 3 years, he kept on asking me questions. So he was very supportive, But the other three examiners were from different colleges, and they asked me, I don't know, hundreds of questions. And I remember introducing certain words from McDonald's, Dean and Avery, good topics that I really liked, especially the medically compromised ones. And I answered most of it, and I think I faltered in histology. I still remember that question, the answer of which I do not know even yet, and it was, how fast does a tooth develop? Yeah, that was a question. They wanted to know every day how much the tooth bud grows. That was their question. I was like, I don't know. And I was being very honest and genuine there, like I have always been. The questions which were asked at me, the answers which I did not know, I did not even attempt to think. I was like, I don't know. Like, it's not possible to read everything. And there were some histological stages of some development which I have never even thought that I will go and read, and I did not. And yeah, I did not know that answer. So that was one of the questions whose answer I still do not know. So anyways, I got just carried away. I got nostalgic. It's been 10 years now since I finished my PG. So yeah, anyways, let's go back to this question. Yeah. So when you read a question and you see bite wing, you expect some bite wings. Okay. Now, white non-cavitated lesion can be seen on the distal surface of tooth 2-5. What treatment will you do? Non-cavitated lesion. It is not a hole, so you're not gonna drill it. So basically, it's an incipient lesion. What are you gonna do? Straight away CPP, ACP, that's calcium phosphopeptide, amorphous calcium phosphate, and you call after 6 months. GC tooth mousse, basically. Tunnel prep is drilling, no treatment, no. You cannot sit on incipient lesion. Recall an X-ray after 6 months. That's again sitting and doing nothing. Restore with composite is drilling. So the only answer correct is CPP, ACP. Or even if they would not have given this option and given you application of fluoride varnish, it's still a correct answer. What is the main technical error in the radiograph? See, radiographic errors. Technical error in the radiograph. It's a cone cut. Can you see this? Straight away cone cut. What is seen at the distal surface of the lower first molar near CEJ? Here, 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 here. Remember the presentation that we just saw before we started talking? Cervical burnout, straight away. I do not need to explain you why it is that. It's a band shaped, the knife edge is intact, it's a properly demarcated lesion, cervical burnout. Now this view showed most common error occurred with the bite wing. This view showed most common error occurring with the bite wing radiograph limb, actually it should have been. Okay, at first glance, you might think, okay, what's the error? But if you look closely, there's overlapping out here. A bite wing radiograph should never overlap. Why? Because the purpose of taking a bite wing radiograph is to detect interproximal cavities. So you should never have an overlap there. So whenever it's overlapped, you have to repeat. You decided that the patient requires root planing at specific areas because you remember they had deep pockets. But patient's INR was 2.1. What should be your management? 2.1 in a normal patient without any medication is indicating some problem. So you should not do anything, send him over to the GP. But this patient, if you remember the question, is taking warfarin. And I just spoke to you, if a patient is taking warfarin, it's okay to have INR between 2 and 3. It's 2.1. So for this particular patient, because he's already on warfarin, it's okay to have INR of 2.1. So I will proceed after taking a consent. Now, if in the same patient, I had to do some gross surgical disimpaction of a third molar, which would induce a lot of bleeding, I would not directly proceed. I would first send him to GP, get clearance, and then do the procedure. So because I was just doing a root planing, which is not such a major invasive procedure, for me, the INR of 2.1 in a patient taking warfarin is okay just to proceed by myself. So various factors will decide your answer, though all the answers may be correct. Understood? So I hope you understood this part and the other things that I spoke about. Please take this topic seriously. Go and read more on radiological errors. Open your White and Farrow textbook. Go to Google, search radiological errors on IOPA, on bite wings, on OPG. Go through 2-3 different PPTs, make your own notes about it, click some pictures, keep it in your notes, go through them at least once a week. That is how you study. Understood? Have a nice day. And for all the new candidates who are watching this video, you can email me on adcwrittenmocktest@gmail.com to know more about the courses. Bye-bye.